Hey guys, welcome back to the show today. And today I'm going to be continuing our conversation on menopause. And when I say menopause, I'm also sort of talking a little bit about perimenopause and postmenopause as well. But this series I started last week in the show. And this week I'm going to pick up with women's health, which I'm going to call this women's movement health, and how menopause affects your joints, muscle health, and your movement quality. Now, this past weekend, while I was working out in my flower beds, I listened to Peter Attia's podcast. He was talking with Dr. Abbie Smith-Ryan, who is an exercise physiologist at the University of North Carolina. And the title of the episode was Women's Health and Performance, and how training, nutrition, and hormones interact across life stages. And if you haven't heard the podcast yet, it's a great one. It's a great conversation between two people who are deeply serious about what is actually happening to women's bodies through perimenopause, menopause, and the years after. Now, I listened to that episode and caught two moments where both of them asked a question, but both of them had no clear answer. One was on tendons, specifically about loading and jumping in a perimenopausal body and the fear of tearing something. And the other was about balance and falls and what happens with an older postmenopausal female is bumped or she trips and cannot catch herself, so she falls. And I want to bring my science to those questions today, the science around movement health, because there is a piece of this picture that lives upstream of the muscle, the hormone, and of the tendon that did not come up in their discussion. And in this conversation I have with women in menopause, I talk about these things in my studio every day. And today I want to talk about this same subject with you. I also want to bring to the table a new word. They mentioned a new word in the podcast, and I want to teach you what that word is and what it means for your movement health. And the word is metabolic flexibility. Now, I had not heard that term before. I've heard of metabolic dysfunction, but they really, in this podcast, talked about metabolic flexibility and inflexibility. And I had to go back to the research after listening, and I want to share what I learned with you. Now, a quick word about what I am bringing before I start. I am a movement specialist, and I focus on the healthy movement and how you can control the decline that happens in your joints and muscles before it becomes a diagnosis and causes you to experience pain. Now, some of you have experienced pain already. I do work with those people because they've been through the healthcare system and have been discharged or it didn't work. So my focus of care is testing movement and tracking movement that is not healthy. And I offer programs that help you get back lost joint mobility that you thought was gone for good. And the hormone therapy and medical pieces I mentioned are from their show. They're just to help you connect the dots for your movement health. I am not a doctor or a scientist. What I am bringing today is the joint capsule and the movement system science that I have not heard connected in this conversation yet. And that's my lane. And I think it completes the picture they were drawing in the show. Now, I guess I need to ask you first, have you heard of the word metabolic flexibility? I had not heard of it. I had to look it up, and this is what I found out. This is how it affects the things that are going on in your body right now in perimenopause, menopause, and postmenopause, okay? And this word is key for that. And here's what I found when I dove into the research. The term was coined by Kelly and colleagues in 1999, and the modern definitive review was by Good, Pastor, and Sparks in Cell Metabolism in 2017. And the definition of metabolic flexibility is the ability of your body to switch between burning fat and burning carbohydrate based on what is available and what your body is demanding at that time. After a meal, a healthy body switches into glucose burning and stores away the excess. Between meals and overnight, it's going to switch back onto fat burning. And that switch is automatic and seamless in a person who has metabolic flexibility. Now, when the switch breaks down and you say stuck, then glucose stays elevated after meals because your body cannot get it out of your blood and into the cells that should be burning it. Fat does not get access between meals because your body cannot toggle back to burning fat the way it used to when you're in menopause and postmenopause. Now, the broken switch has a name in the literature, and that broken switch is called metabolic inflexibility. It is the engine underneath insulin resistance, type 2 diabetes, and most of the metabolic decline that shows up in all of us in midlife. And the site of metabolic flexibility, I bet you're not going to be able to guess this. Skeletal muscle. Yes, specifically type 2 fast twitch fibers. And I want to dive more into these type 2 fibers and their role. But right now, I want to break down muscle because muscle is the largest insulin sensitive organ in your body. And if your muscle is smaller and weaker, your switching capacity is smaller and weaker. And if you've been listening to my show, you should recall me breaking muscle into muscle health category. This is to help you see the complexity of skeletal muscle and what the muscle requires to be healthy. A healthy muscle can build strength. An unhealthy muscle feels weak, but the engine underneath the muscle is causing a muscle decline and a loss of muscle function that is larger than what we perceive as weakness. And it is that I want you to better understand as I break this down today. Now, body composition changes in midlife due to many things. Aging is only one of those things, but a large change in body composition changes come from the loss of skeletal muscle. And as women in midlife, this loss seems to cascade for us. Body composition is the visible result of a muscle system that lost some of its switching capacity. And many of us are not as hungry as we used to be. And because we are gaining weight, most of us are okay with eating less during this time of life because we want to lose that weight. But I want you to know it is important to look at the research here and choose things that help improve your metabolic flexibility. The fix is not eating less, okay? So try to resist this urge because to be able to build muscle, which is your end goal, you're going to have to eat enough protein. And even if you're hungry or not, you're going to have to get protein in. And that is a very hard thing for females at many ages and certainly, midlife and beyond. The fix is preserving and rebuilding muscle so that your switch can be turned on like it should be. And then, it can switch back and forth. Now, after a meal, a healthy body switches into glucose burning and stores the excess. Between meals and overnight, it switches back to fat burning. That switch is automatic in a metabolically healthy person. And when it breaks down, you're going to stay stuck in sort of one fuel pattern. Your glucose is going to stay elevated after meals because your body can't get it out of your blood and into your cells. Fat does not get accessed between meals because the body can't toggle back and forth, okay? The switch is broken, and this is called metabolic inflexibility, and it's the engine underneath insulin resistance, type 2 diabetes, and most of the metabolic decline that shows up at midlife. Now, here's the part that connects this to everything to your joint and your muscle health. The site of metabolic flexibility is your skeletal muscle, specifically the type 2 fast twitch fibers. Muscle is the largest insulin sensitive organ in your body, and type 2 fibers have most of the glucose transporters that pull glucose out of your blood after a meal. So if you have less muscle and especially less type 2 muscle, your switching capacity drops. Now, that's the simplest version of what I learned. The metabolic flexibility conversation is a muscle conversation and specifically a type 2 muscle fiber conversation. Now, here's why metabolic flexibility matters for you. When you hear people talk about metabolic flexibility, they're talking about whether your muscle can still do its job as the switching engine for your fuel. Body composition changes in midlife, and it's during this time we see decreased wellness health scores, increase in visceral fat and fat around your abdomen, and we also see muscle health, joint health decline. They are the visible result of a muscle system that has lost some of its switching capacity. Again, the fix is not for you to eat less. The fix is preserving and rebuilding the muscle that runs the switch. Specifically, the type 2 fibers are what we're going to be talking about, but I'm going to get into those type 1 fibers as well, because there's 2 types of muscle fibers. Now let's talk about these falls. Falls are actually an epidemic in the senior population. Now, I want to talk about how does a fall relate to metabolic inflexibility, joint and muscle loss. Now, in the episode, Peter raised something that I could have answered, but of course I was not the one being interviewed. He talked about how an older adult who gets bumped or trips often cannot catch herself. So she or he will fall, and this fall is the beginning. It seems minor, and most of our parents will have this type of fall, or maybe you've fallen, and they're going to laugh it off as not knowing what happened. Now, guys, our body cannot recover the balance fast enough. So during this time period in our lives, Peter framed this as a concern most Americans having lost the type 2 muscle fibers that is needed to react in these moments. He wanted to know what the research said about it in the show, and Dr. Abbie told him that people should go to see a PT or a personal trainer. And then Peter said there's a large gap of experience with the midlife population when we're talking about personal trainers. And I felt the listener was left with, what do I do to gain these type 2 muscle fibers so that I can help my parents decrease their fall risk and help me and my family prevent falls as we are all going through this midlife change. Guys, we start losing muscle in our early 30s. And for someone who is also hypermobile, it can be sooner due to the laxity in their joints. The muscle loss is triggered by the joint, and this is the area that is not addressed at the source. And it's not addressed consistently and under what it needs to be addressed as far as frequency is to make changes. So let's dig into the muscle fibers for a bit here so you can better understand them. The fiber you lose first is the type 2 fibers. Now, your skeletal muscle is made of 2 main fibers, type 1, which are your slow twitch, and type 2, which are your faster muscle fibers. Type 1 slow twitch handles your endurance and your posture. Type 2, the fast twitch ones, handle power, speed, propulsion, and reaction time. And type 2 fibers are the ones that fire when you start to fall and your body has to throw a hand out to catch your counter. They are the ones that fire when your foot catches on a sidewalk crack and you have to have like that second to put your other foot down before you hit the ground. They are also the ones that fire when you reach to grab something falling. Type 2 is the catch yourself fiber, okay? It's also the propulsion. That's where our power goes. And this fiber also handles our speed, our power. Now, I don't know about you, but I don't want to lose any of my power, but I have felt that loss over the last few years. And you're already feeling it too, and you're already losing it if you're in that perimenopause, menopause, and postmenopausal midlife time period. I guess I want to raise a hand of those of you who are already feeling that loss of power. Comment. Let's get a discussion going on this so that you can learn more. Now, the research is clear that type 2 fibers atrophy. That means they get smaller, they lose muscle mass, and they lose muscle function and muscle health. And this happens preferentially with aging. Now, some of the reviews, there was some research that described type 2 fibers as 10 to 40% smaller in the elderly compared to a younger population. Now, type 1 fibers stay relatively similar in size. So you lose the fast-catching fibers first, and you keep the slow endurance fibers longer. But by the time most of us are in our 60s, we have already lost a significant portion of the type 2 muscle fibers that we had when we were 30. And guys, this is compounded for us because estrogen also drops at menopause. And the hormone estrogen, that decrease is global throughout our skeletal muscle, along with the joints and the tendons. And the muscle research suggests that estrogen helps preserve muscle contractile speed and quality. So when our estrogen drops, the type 2 muscle fibers atrophy. This will actually accelerate beyond what age alone would do. Now, Peter's concern about people being bumped and falling is exactly the right concern. And most of us are unaware of the role of the loss of estrogen at menopause and how it affects our movement throughout our lifespan, especially that 5 to 7 years after menopause. Let's dig into this metabolic flexibility and these muscle fibers and how and what it means for you specifically. Metabolic flexibility as it relates to the health of your skeletal muscle is key during midlife at all stages, okay? And strength training alone will not rebuild your muscle and stop the muscle loss that is already happening. You can maintain, but you're not going to build that extra, and it's because the health of the muscle is not there. It's not functioning the way that it's supposed to function anymore. And if you've had weight gain and you can't seem to get rid of it, that is already your first sign that your muscle switching is delayed or it's not working properly at all. And as discussed above, this is metabolic inflexibility based on the literature. Now, muscle loss is occurring 3 to 8% during midlife, and it increases when we reach the age of 60 and beyond. It's like we're on a cliff and we're about to fall over, guys. And what you don't know is that you're thinking when you fall over, there's something there to catch you. But I'm here to tell you guys, I see these ladies postmenopausal go into rotator cuff tears, go into hip dysfunction within just a few days because of a cycle that happens in your body. Now, this muscle loss relates to your deep muscles that support your joints and your larger muscles that move your joint. Both of these muscles are in decline, and when your joint and muscle are in decline, I call this the silent shutdown cycle. When you add menopause to the top of that, then we have aches and pains and stiffness in our joints, and you can feel it more when you're sleeping. It disturbs your sleep. It's so many things. Menopause really just sucks. Now, your type 2 muscle fibers are lost with the loss of end range joint mobility. So what that means is the joint mobility that you're losing in your thoracic spine, in your hips, in your ankles, in your wrist, and all of those joints, all of them comparatively, you're losing end range joint mobility. And the ones we're seeing it in right now are thoracic spine, shoulders, hips, and ankles. So if you have lost joint mobility, and you're not going to know that you lost it, and I'll go through that again, but when you've lost that end range joint mobility, your body sort of takes it away. It's sort of like this glass, let's say this is your joint mobility. And by the time you hit menopause, you've already lost this much of that end range. And now your joint mobility and those, shoulders, thoracic spine, your hips, and your ankles, you only have this much available range to move in. And this is a limitation, okay? Until you get all of this back, you're not going to get those type 2 fast twitch muscles because you can't gain that on a system that's being inhibited. You can practice it and you can learn things, but you're not going to gain it until you gain that end range joint mobility. That is driver 1 of the 5 drivers of movement health. And when someone bumps you in a crowd, your type 2 fibers are what stabilize you. They're what are required to prevent a fall, along with making sure that you have good joint mobility. Now, it's during midlife we lose bone due to the cascade of the silent shutdown cycle and the loss of muscle health and strength. We need to preserve muscle during this time to prevent the loss in skeletal muscle and prevent the loss of joint mobility decline, as well as that global aspect of the cascade that happens with menopause. Now, this is the cascade Peter was pointing at, and it's the most underestimated cycle that is not being addressed in midlife. Most of us have no idea, except for we know we're achy, we know we're not sleeping well, we know we're having hot flashes, we've got the changes of life going on. And while we're going through that, there's a lot more that is being taken away from us. And I want you to understand that because this has huge ramifications on your movement health. And the type 2 loss is completely silent. You will not feel pain. It does not hurt. and there is no symptom that tells you that it is happening. The first symptom is the fall. Now, the falls don't stop with just balance training, and balance training is the most utilized treatment for fall prevention. We need to look more at the joint and muscle health. Another unaddressed important factor is the general loss of muscle mass. Now, this is the function of the muscle we're losing, but we explain this loss of function more as weakness, and this is what we need to pay more attention to. Metabolic flexibility is a new term for me, but it comes down to muscle quality and muscle health. You don't just turn metabolic inflexible overnight. This is part of the silent decline that I discussed that happens starting at the joint level, then turns off the muscle cascade that leads to falls and joint and muscle conditions. Now, I want to talk about Abbie's concern. The second thing that she talked about was the fear of a tendon tear with loading. We know the research supports loading our joints to preserve tendon health. And she was concerned about this because she is already feeling tightness in her joints and relating it to muscle health. Now, she was speaking about her own concern around this loading aspect, and she presented the research on jumping and loading and how important it is for hypertrophy and tendon health. She is a researcher who actively trains, and she talked about the fear of tearing her Achilles tendon if she pushed too hard into jumps or loading during this stage of life. That is an informed researcher saying she has seen something in the literature that worries her about her own body. And I want to validate what she is concerned about because she is not the only person who has this fear. In fact, fitness shows us to push harder and also gives us ways to tape our joints for protection. And this is the gap that stretch mobility coaches address. And we address this through proven methods that improve end range joint mobility in the hip and the foot system. And this is an important misstep. And I want you to see that you do have the things that you can do during this time. You just need to have the right things and do them in the right order. Now let's talk about what happens to your tendons during menopause. Tendons are made largely of collagen. Estrogen supports collagen synthesis and tendon health. And before menopause, women actually have lower tendinopathy rates than age-matched men, and that advantage disappears after menopause. Now, the Ganderton and colleagues systematic review in the Journal of Musculoskeletal and Neuronal Interactions, it was in 2016, they documented that as estrogen declines after menopause, collagen production can decline, tendons become thinner, and rates of tendon pathology and rupture increase. Estrogen receptors are present in tendon tissue. And when estrogen drops, the receptors that were supporting tendon maintenance, they lose their signal. Now, postmenopausal women, and again, guys, this is after age 52. It's going to vary for many of us. It's 5 to 7 years after our last cycle, but that does change different surgeries and such. But postmenopausal women have lower collagen density in their tendons, and it's slower and harder to heal after micro trauma. And it takes us longer to heal than it did when we were in our 30s. Now, Cook and colleagues in the Scandinavian Journal of Medicine and Science and Sports in 2007 found that physically active postmenopausal women on hormone therapy had different Achilles tendon characteristics than non-users. And this just suggested that hormone therapy may support tendon health in this population. This is not me supporting or not supporting something. I'm just giving you the data. Now, the research shows that red light therapy can aid in tendon health and muscle recovery, as well as having bone benefits. Research also shows that limited ankle dorsiflexion is a proven risk factor for Achilles tendinopathy. Restoring in-range ankle joint mobility. And guys, it's not just the ankle here, okay? Because without in-range, your tendon cannot be loaded through its full length, which is what the research shows is required for tendon adaptation. So when Abbie said she was scared of tearing her Achilles with loading and jumps, she was reading the research correctly. The tendon environment in a postmenopausal body is more vulnerable. Pushing high impact loading into that environment without preparation is a real risk for this population. And I want to break down what Dr. Abbie and Dr. Attia did not fully understand or conclude in the episode that I listened to. Peter wanted to know how to train the fall risk away. Abbie wanted to know how to load without tearing her Achilles. Both of them were in the same problem from different angles. How do you build type 2 fibers and load tendons in a postmenopausal body that it needs desperately? And also, the body is more fragile than a body that trained at age 30 or 35. They both correctly pointed at strength training and progressive loading as the answer. They are both right, but there is a piece they did not discuss, and it's the piece that determines whether the loading gives your tendons fully what they need or it ends in the exact tendon tear that Abbie was afraid of. And that piece is upstream to the muscle, upstream to the tendon, and it is the joint. And it is this conversation that is so important. And there's a huge gap currently when we discuss treatments and programming for this population. Now, here's what completes the picture. This is the part of the conversation that is mine, okay? I've not heard either of them or anyone else in the high performance menopause space talk about it yet. And I think when you hear it, the tendon fear and the fall concern stop being two different problems and become more of one problem with a known upstream cause. Now, when we look at the 5 drivers of movement health and the silent shutdown cycle, all of the falls, the tendon tears, they decrease with addressing these 5 drivers. The first driver is joint health. Making sure to maintain joint end range mobility is key to loading a tendon through its entire range in a healthy way. And for falls, we can keep joints strong and mobile when we can keep them from losing more joint mobility. Now, let's dig into the silent shutdown cycle. Long before menopause, your daily life of sitting, driving, repetitive desk work, sleeping on one side and that same side, all of these things place pressure on your joints and your body. And this leads to a joint restriction of the moving joints, which are your thoracic spine, your hips, your shoulders, and your ankles. Now, the joint capsule is a sleeve of tissue that wraps around joints and wraps around the bone, shall we say. And I don't have one here in front of me right now, but this is a sleeve of tissue that wraps around the bone, and it loses its normal in-range mobility year over year. And you'll not feel pain or symptoms during this time because pain is what shows up last. And by the time pain signals, you already have many joint and muscles that are in decline throughout your body. And when a joint capsule restricts, there are mechanoreceptors inside of it that send altered signals to your nervous system. And then your nervous system responds by quietly turning down the deep stabilizing muscles around the joint. And this causes your joints to be unsupported, and it primes them for restriction. Now, this is documented in the neuromuscular phenomenon, and the medical term is arthrogenic muscle inhibition. The foundational reference is Hopkins and Ingersoll in the Journal of Sports Rehabilitation in 2000. The deep stabilizers are delayed or absent because the nervous system is called to protect the joint that has lost normal capsule mobility. Now, in my work, I call this whole process the silent shutdown cycle because it runs silently for years without any pain. Now, here's how it connects to the tendon fear. Now, neither Peter or Abbie raised this that I'm about to talk about in the episode. A jump and a heavy load do not go through your muscle in isolation. It goes through your joint. And if the joint capsule has lost mobility and the deep stabilizers that are supposed to protect that joint have been shut down by arthrogenic muscle inhibition, which is also AMI, the joint can't center itself under that loaded pressure, and it absorbs the force in a compensation pattern. Your larger muscles, those are like your biceps, your quadriceps, your hamstrings, your glute max. Those muscles take over jobs they weren't built for. The tendon attachments to those muscles end up loaded in positions and at angles they were not designed to absorb. And they're not going through that full range that they need to impact that the research shows us that is required. Now, when you layer that on top of a tendon that is already more fragile because estrogen is dropped, you have a tendon with weakened collagen being loaded by a body that cannot center the joint above it. And that is the recipe for an Achilles tear that Abbie was afraid of. And it is not that loading is wrong, because the research supports loading, but loading is what postmenopausal women need most. It is also loading into a shutdown movement system. That is what I'm saying is wrong, okay? The order matters more after menopause than it did in our younger years. And this is what I want you to walk away with today from this episode. Now let's connect this to the falls where Peter had his concern. Peter talked about the type 2 fast twitch fibers and what we lose first with aging and how they are critical for catching a fall. And the research backs this. Power declines before strength, and strength declines before size. Now, type 2 fibers of these muscles atrophy. They get smaller, they lose function, and they atrophy faster than type 1 with age, which is why an older adult can lose the ability to react fast enough to recover from a stumble. And the muscles that actually generate the force to catch a fall are the larger type 2 dominant muscles. These are your quadriceps, your glute max, your gastrocnemius. These are the explosive power muscles Peter is talking about when he says train these type 2 fibers to prevent falls. These are the layers of the specific muscles, okay? But guys, you can't prevent a fall in a joint that doesn't have full mobility, because then you've got that silent shutdown cycle happening. So you can't get rebuilding and strength in a muscle that can't get the full load through the tendon, that also can't get that full mobility through the joint. Now, here's layers of the specific muscles, okay? Layer 1 is type 1 deep stabilizers. Those are like your multifidus and your transverse abdominis. Those are the first ones that are inhibited by this silent shutdown cycle. The multifidus is one of the deep muscles that protects your spinal joints posteriorly, and the transverse abdominis protects these joints anteriorly. And these are the feed forward muscles that pre-activate before you move. Now, when they shut down, your body loses its early warning and stabilization system. You stop sensing the stumble with this shutdown of the deep muscles. Now, layer 2 are the type 2 larger muscles like your quadriceps, your glute medius, your gastrocnemius. They actually get inhibited by AMI as well. And these are the muscles that Dr. Attia is talking about when he says you need fast power to catch a fall. And when they shut down, you do not have that explosive recovery force, even if you sense the stumble. And many of you have been here before. You've sensed that stumble and you just keep going down. It's like this slow decline to the ground. Now, when both layers are shut down, you cannot detect the fall coming and you cannot generate the force to catch it. And that's the silent shutdown cycle in full effect. And that is why it's not a fitness problem. It is an operation systems problem. Now, the silent shutdown cycle inhibits both deep stabilizers that fire before you move and the larger type 2 muscles that catch you when you stumble. And Peter Attia is right that we need to train type 2 fibers as we age. But guys, the missing piece is that no amount of fast twitch training will overcome a nervous system that has been shut down. And when those muscles are shut down through AMI, you have to restore the system first. Now, a type 2 fiber that is being told by the nervous system to stay turned off, to stay inhibited, it does not fire. And because you have been strength training the muscle around it, it doesn't turn it back on. The strength you build in a body in shutdown reinforces compensation patterns, and it leaves your deep stabilizer shut off. The corrective step that should catch the fall is still missing because the muscle that produces it is still inhibited. You can lift heavy 3 days a week and still go down when you trip if your deep stabilizers are not reactivated. Then you have to address the larger muscle groups. In this silent shutdown, they are holding the joint, those larger muscles, and they are losing mass and losing health, and they're getting tight. And these require addressing driver one, which is the joint, along with driver two, deep muscles and larger muscles. Both are going to make it a more complete process, but you also need to address the other drivers for movement health. Every single one of them are important. Now, that's the piece that completes this conversation. Train type 2 with loading, yes. Load tendons progressively, yes. And restore the capsule mobility and the stabilizer activation first so that the loading lands on a body that can absorb it. Make sure your body is not strengthening in compensation. Now, the order is testable and the missing piece is measurable, and this is what I do. Now, here's the order that would complete their protocol that they're talking about. If I could put my work in the middle of their conversation, here is the order I would offer for a post-menopausal woman who wants to do exactly what Peter and Abbie are prescribing. Train hard, load tendons safely, build type 2 fibers, catch herself when she falls or when she trips, stay metabolic flexible, and avoid the surgery list. Now, here's how you go about doing that. Number one, you need a mobility health assessment, and this is going to test every joint in your body and not just painful joints. This is going to measure whether the small joints in your spine, your hips, your shoulders, and your ankles have lost in-range mobility, and whether the deep stabilizers around them are firing or not firing. And it's going to produce a mobility health score, and it's going to produce a movement age. Now, this is the baseline that tells you what kind of body you can load and if it's safe to do that. Overloading a weak muscle and a tendon in decline can cause a tear. We've seen that in the literature. Step two is to unlock these joints, okay? This is where the assessment shows capsular restriction, and then we restore mobility with hands-on work matched to where the restriction is. And the capsule has to be addressed first because it is the input that's keeping the deep stabilizers inhibited. And once the capsule moves, the nervous system stops sending that shutdown cycle. Step three is you have to reactivate these deep stabilizers that have gone quiet, and they have to be brought back before any explosive or heavy loading goes through the joints. Now, your daily homework, once you have addressed driver one and driver two, is to do 5 to 10 minutes of targeted activation. Now, this is the unglamorous step of every loading program, and this is what every loading program skips. Most programs show us activation drills of larger muscles, but do not follow the complexity that is required to activate and keep those muscles activated. Unfortunately, guys, the inhibition is not a one-time occurrence, and you cannot gain all in-range mobility in one session and keep it. It is way more complex programming and testing that is required to successfully do this, and it's also the step that decides whether your tendons absorb the load safely or whether they tear under stress. Now, step 4 is to load, including your type 2 specific ones. This is what Peter and Abbie were prescribing. You can actually load resistance training for muscle, impact loading for bone in the dosage the research supports, and it's critical for type 2 fiber preservation and reaction time, fast and powerful loading. You want to do plyometric work where it's appropriate, Olympic style movement at appropriate doses. The Lift More randomized controlled trial by Watson and colleagues in the Journal of Bone and Mineral Research in 2018 showed that postmenopausal women with low bone mass who did supervised twice weekly high intensity resistance and impact training for 8 months gained about 4% lumbar bone density. Now, the work is going to work, but the key is that the body is prepared for your movement system so that it works efficiently. Now, step 5 is to maintain. And guys, estrogen doesn't come back, and that's why you need to consult with your doctor to see if estrogen is something you need to add back in or not. That's a conversation you have to have with your doctor. The silent decline cascade does not stop no matter whether you take estrogen or not. In fact, we see it return after small activities, stress, anything. The biggest thing here is understanding this cycle, and this becomes key because maintenance is not optional, and the frequency is set by testing and not by how you feel. You test, you check your in-range mobility, you adjust, and you progress your programming. And the mobility health score and the movement age are just instruments. And that is how you know that your work is holding. Now, I want to close this up today, and I want you to walk away with the word metabolic flexibility, how it lives in your muscle, and especially in your type 2 muscle fibers. Type 2 muscle fibers is what catches you when you trip. Type 2 is what disposes glucose after a meal. You are losing it faster after menopause, and Peter and Abbie are right that you need to rebuild it. Tendons are more vulnerable after menopause, and Abbie was right to fear that Achilles tear. The research supports her concern. Postmenopausal tendons are thinner and slower to heal and more prone to injury. And both of those are real, and both of those are addressed by training. But the piece that determines whether the training builds type 2 fibers safely or whether it tears the tendon is what Abbie was afraid of, is the joint capsule and the deep stabilizer inhibition and the compensation that lives upstream of the muscle and upstream of the tendon. Now, that's the upstream conversation that did not come up in their episode, and it is the one that completes this picture. And if you are training your body and it feels off, you're afraid to load it like Abbie said she was, and if you have been bumped lately and you notice you almost didn't catch yourself like Peter described, your joint capsule and your deep stabilizers are sending you a signal, guys. You need to book an Unlock Your Healthy Joint Mobility session. You can do that at Beckett Ridge here in the studio, or I also offer in-person and virtual sessions. One session, you're going to get your mobility health score and your movement age, and that's going to tell you a lot, okay? Then you have the upstream picture that the highest level menopause performance conversations are still missing. And then you can load with confidence without fear. Peter and Abbie gave you a great conversation, and I'm bringing the piece they couldn't answer. Now you have everything that you need so that you are set up for success. I look forward to seeing you in the studio, and I'll see you next week here on the show. Until then, keep moving well.